Welcome back to Mastering Medical, Part 2 of Cardiology, Heart Failure, the Cardiomyopathies, and Pericardial Disease. We sort squeeze from fill, left from right, muscle from pericardium, and finish with shock. Let's go. We open with the cardiomyopathies. The first split is mechanical. Is the heart failing to squeeze or failing to fill? Dilated is a systolic problem. Hypertrophic and restrictive are diastolic. Dilated cardiomyopathy is a systolic problem. The chambers dilate, the walls thin, and the ejection fraction drops, with a third heart sound gallop. Think alcohol, viral myocarditis, genetic mutations, doxorubicin, and the peripartum period. Hypertrophic and restrictive cardiomyopathies are diastolic problems with a preserved ejection fraction. Hypertrophic cardiomyopathy is asymmetric septal thickening with dynamic outflow obstruction, the classic cause of sudden death in a young athlete. Restrictive cardiomyopathy is a stiff, infiltrated ventricle from amyloidosis, sarcoidosis, or hemochromatosis. Cardiac amyloid is the buzzword, with a low voltage ECG despite thick walls. So a low ejection fraction with dilation is dilated, while a preserved ejection fraction with stiff or thick walls is hypertrophic or restrictive. Now left versus right heart failure. Picture where the blood backs up, into the lungs or into the body. Left-sided failure backs pressure into the pulmonary circulation. So you get dyspnea, orthopnea, crackles, pulmonary edema, a third heart sound, and a high BNP. The usual drivers are ischemia and hypertension. Right-sided failure backs pressure into the systemic veins, so you get jugular venous distension, a congested pulsatile liver, ascites, and peripheral edema. The key point: the most common cause of right-sided failure is left-sided failure. So when you see isolated right failure, go hunting for a lung cause like cor pulmonale. Lung congestion is left, body congestion is right. When the right heart is failing, the next question is why. Is the problem starting in the lungs, or is the left heart dragging it down? That is cor pulmonale versus left heart failure. Cor pulmonale is right ventricular failure caused by the lungs or the pulmonary vasculature, chronic obstructive pulmonary disease, interstitial lung disease, or sleep apnea raise pulmonary pressures until the right ventricle gives out. You see a loud pulmonic second sound, jugular venous distension, and edema, but the left ventricle is working fine. Left heart failure starts in the left ventricle and congests the lungs first, with crackles and a third heart sound, and only later strains the right side. So right heart failure with a normal left ventricle and a lung cause is cor pulmonale, while a failing left ventricle from the start is left heart failure. Two diseases that both stiffen diastolic filling and look almost identical: restrictive cardiomyopathy and constrictive pericarditis. Is the stiffness in the muscle or in the pericardium around it? Restrictive cardiomyopathy is a stiff myocardium from infiltration, amyloidosis, sarcoidosis, or hemochromatosis with biatrial enlargement, and the cardiac amyloid clue of a low voltage ECG despite thick walls. Constrictive pericarditis is a stiff pericardial shell wrapped around a normal muscle, classically after tuberculosis, chest radiation, or cardiac surgery. Look for pericardial calcification, a pericardial knock, a Kussmaul sign, and exaggerated ventricular interdependence on breathing. So infiltration of the muscle is restrictive, while a calcified external shell with a knock is constrictive. Staying on the pericardium, constrictive pericarditis versus cardiac tamponade. Is this a chronic rigid shell or acute fluid squeezing the heart? Constrictive pericarditis is the chronic slow problem, a rigid, often calcified pericardium with a Kussmaul sign, where the jugular pressure rises with inspiration and a pericardial knock. Cardiac tamponade is the acute emergency. Fluid accumulates under pressure and chokes filling, giving Beck triad, which is hypotension, jugular venous distension, and muffled heart sounds, plus pulsus paradoxus, a big drop in blood pressure on inspiration, and electrical alternance on the ECG. Echo shows the chambers collapsing. So chronic with a knock and Kussmaul is constrictive, while acute with pulsus paradoxus and muffled sounds is tamponade. Both of these cause obstructive shock with hypotension and distended neck veins. The exam splits them in seconds. listen to the heart, then the lungs. Both give hypotension and distended neck veins. Cardiac tamponade adds muffled heart sounds, pulses, paradoxus, and electrical alternance from fluid around the heart, and you treat it with pericardiocentesis. Tension pneumothorax adds absent breath sounds and hyperresonance on one side, with late tracheal deviation away from the affected lung, and you treat it with immediate needle decompression. So, in obstructive shock, muffled heart sounds point to tamponade, while a silent, hyperresonant chest points to a tension pneumothorax. We finish with shock. The bedside split is temperature and the pump. Is the patient warm and vasodilated or cold with a failing heart? Septic shock is distributive. Infection drives massive vasodilation, so the systemic vascular resistance falls. The extremities are warm early, cardiac output is high or normal, and the lactate is up with a clear infection. Cardiogenic shock is pump failure. Cardiac output drops, so the patient is cold and clammy, with pulmonary edema, a high jugular venous pressure, and high filling pressures, meaning a high pulmonary capillary wedge pressure. So warm with low vascular resistance is septic, while cold with pulmonary edema and high filling pressures is cardiogenic. Lock it in. Cardiomyopathy. Low ejection fraction with dilation is dilated. Preserved ejection fraction with stiff or thick walls is hypertrophic or restrictive. Heart failure, lung congestion is left, body congestion is right, and left failure is the top cause of right failure. Right heart failure with a lung cause and a normal left ventricle is core pulmonale, and stiff filling from muscle infiltration is restrictive cardiomyopathy, while a stiff pericardium is constrictive. Pericardium, a chronic calcified shell with a knock and Kussmaul sign, is constrictive pericarditis, while acute fluid with pulses, paradoxus, and muffled sounds is tamponade. In obstructive shock, muffled heart sounds mean tamponade, and a silent hyperresonant chest means tension pneumothorax. And shock itself, warm with low vascular resistance is septic, cold with pulmonary edema, and high filling pressures is cardiogenic. That is part 2. Part 3 takes on ischemic heart disease and the aorta. See you there.